This month's Lunch and Learn with the National Bone Marrow Transplant Link will cover the latest on chronic GvHD, trials, research, and what's on the horizon. Our guests will be Dr. Farid Farr, a nationally recognized expert in the field. Additionally, survivor Steve Hodges will provide his best tips and tricks. This month's Lunch and Learn with the Link will be Wednesday, February 19th at noon Eastern. Sign up for free by visiting nbmtlink.org or just follow the link in our show notes. Welcome to Season 16 of Marrow Masters, sponsored by Sanofi. The National Bone Marrow Transplant Link, established in 1992, strives to help patients, caregivers, and families cope with the psychosocial challenges of bone marrow transplant, from diagnosis through survivorship. Season 16 of our show will focus on the best tips for dealing with chronic graft-versus-host disease. Top-notch healthcare professionals will share their compassion, best advice, insight, and caregiving tips regarding chronic GvHD. This season will offer education, tried-and-true solutions, stories of hope, and more. Now, here's your host, Executive Director of the NBMT Link, Peggy Burkhardt.
Hello, everyone. So today we have with us Josh Conklin, RN, BSN, a bone marrow transplant certified nurse at the University of Michigan Hospital in the Adult Blood and Bone Marrow Transplant Center. So Josh has worked inpatient for 11 years now, and he's going to share his wisdom today and his best tips regarding how he deals with chronic GvHD and helps his patients. Welcome, Josh.
Thank you for having me today, Peggy.
Oh, this is going to be great. Thank you. So, Josh, let's jump right in. Can you share with us details about your role as a nurse on a transplant for specifically inpatient?
So my role as a BMT nurse is mainly to provide care to patients who are in the immediate phase of their bone marrow transplantation. The chemo that they get leading up to their transplant, which is their conditioning chemotherapy, and then performing the stem cell infusion and the care immediately afterwards while they're in the hospital. Usually the most vulnerable time that a BMT patient has is the initial hospitalization for the actual stem cell infusion and transplant. So that's the stage of care that I provide most of the care to and where I see most of my patients.
Okay. Thank you. Gosh, that must be challenging at times, but I think of the people you're helping and I'm sure you make their days a lot better. So Josh, let's talk about why graft-versus-host disease really is necessary for the graft-versus-leukemia effect to take place.
Yeah, so it's a kind of a complicated process, but for most unrelated bone marrow transplants, what they're looking for is not to get to a full remission, but a chance for their new stem cells, their new immune system to have sort of this underlying suppression of the cancer themselves. So their new cells sort of take hold in their bone marrow, and then they provide the treatment, so to say, against the cancer getting out of control again. So it's kind of like we want a low level of GvHD that fights the cancer, but not so much GvHD that it starts causing problems in other areas of the body.
Basically, you want to find that sweet spot, which of course you can't control. You just hope for it.
Yes.
A little bit's good, too much is not so good.
Correct.
Yeah, we hear that again and again. So Josh, let's talk about long-term immunosuppression when it relates to GvHD, the frustration, the best practices for success, why it's important.
So long-term GvHD can be difficult. It depends on, again, the severity of GvHD. I think all patients who get unrelated transplants, meaning the cells from a stranger or someone related to them, have some form of GvHD, the severity of which depends on the treatment that they get. All patients start out with some immunosuppression. Usually tacrolimus is what we see the most or use the most at the University of Michigan. And if there are acute flare-ups of GvHD, then usually the first line of treatment is steroids. And that's usually not the greatest thing to use long-term because they have so many side effects. You know, they cause muscle wasting and deconditioning, and they make you more immune suppressed. So you're at much higher risk for infections. And that's long-term. I think that's the biggest risk for patients most of the time is infections. and a reason for most of their hospitalizations or rehospitalizations. But the goal is once we get their GvHD under control with steroids, to get them on some other adjuvant therapies. There's all sorts of mAb drugs or monoclonal antibodies that we use to help control people's GvHDs that are hopefully have less side effects than steroids.
Absolutely. And steroids, oh, what a subject that is. It seems to be such a love-hate for so many of our patients that we hear from.
Yeah, steroids are, it's kind of like a juggling act. There could be so many setbacks with GvHD. You can get it under control and, slowly they taper down the steroids, and then, there's a flare up again, or they end up with some sort of infection that makes their GvHD flare up again, and then they have to go back up on steroids. And it can be really taxing on patients. And I think mentally, obviously physically, but just the back and forth all of the time. Like they just want to be healthy and, stay out of the hospital and live their lives. But sometimes the reality is it's just kind of back and forth. Some patients handle it a lot better than others.
Yeah, I hear you loud and clear. So let's talk about repeated hospitalizations and what's the main cause?
The main cause for rehospitalizations, they're not being admitted solely for a GvHD sort of workup. So, they're having symptoms, they're either having diarrhea or nausea, or they have some sort of rash that's popping up. That's usually the first thing that sort of presents itself when they're getting GvHD.
Mm-hmm.
If it's not one of those things, it's usually an infection. We already know they have GvHD, and it's just from the chronic immune suppression that they have to be on to control the GvHD, they're just so at risk for other infections. Infections are the most common thing that causes patients to be readmitted to the hospital.
As they're getting away from their post-transplant date and, a year or two has gone by, what are the main side effects that you see a little more long-term, a little more chronic?
Some of them can be from the chemotherapies themselves. Not so much GvHD related, but sometimes there can be like lasting brain fog or chemo brain for patients. But from a GvHD perspective, the goal, again, is to taper off of all of their immune suppression. And hopefully, best case scenario, they don't have to be on any immune suppression after the 100 days. Usually that first 100 days after transplant is the most precarious, as far as that's when GvHD, if it's going to be a problem, it's going to present itself within that 100 days, because all of the tapering of immune suppression usually occurs within that 100 days. And the goal is to get off of the immune suppression at the end of that 100 days. So long-term, patients can have symptoms of, usually like dry eyes, or maybe some of our younger patients who are still sexually active. GvHD can be a hindrance from that because our body just doesn't function the way it normally would. Those are things that I don't see very often because I don't want to see they're less serious, but they're less life-threatening, I guess. I see more of the life-threatening complications from GvHD and the inpatient side, so I don't get to manage or have as much experience with, things that are being managed outpatient in the clinics.
Sure. So Josh, we know how important the caregiver is, the monumental role that they play, especially because GvHD lasts sometimes a long time. Let's talk about the importance of a good support system and any tips that you might have for caregivers.
Yeah. All of our patients are screened before they even are approved for a bone marrow transplant to have a solid caregiver plan before they come in for transplant. And hopefully that's the case, but not all patients have, solid caregivers, and that's just the reality of their situation. But caregivers are so important in the long-term success of bone marrow transplant patients. Having someone who lives in the home, who is able to be with the patient, at least 90% of the time, at least also in those first 100 days when patients are so vulnerable to things happening or, bad things happening to them relatively quickly, because we talk a lot about, the recovery of their cells during the inpatient stay when they're here for transplant, that we knock out all their bone marrow, all their blood counts go down, and then we slowly, over a few days, give them growth factors and it brings it back up. And I think a lot of times patients focus so much on that they aren't anticipating, or they just can't fathom the long-term needs that they're going to have.
Mm-hmm.
But they're still really vulnerable within that 100 days and vulnerable to infections and all sorts of things because their immune system is so brand new. It's a brand new baby immune system. So it's still vulnerable.
Mm-hmm.
And having a solid caregiver during that time is so important because patients can get sick really fast, even within 24 hours. They can go from being fine in the morning to having a fever to going septic the next morning
Mm-hmm.
if they're not careful. And having someone there to be, observant of that and be able to check their vital signs and encourage them to take their medications and things like that is so vital.
Mm-hmm.
And sometimes it's not easy. It's hard to be a bone marrow transplant nurse who's, I've been trained in this for so long and I've worked here for so long, and it's very hard to do it. So having a competent caregiver who is willing and able to comprehend and keep everything straight is amazing for patients. Long term, I think it can wear on the caregivers as well. It's just a constant battle with hospitalizations and going back and forth all the time too, and they just want their loved one to be better. But sometimes it's just a struggle.
Well said. So Josh, let's talk about attitude. Do you want to share maybe some of the ways that you try to help your patients cope with having a long-term chronic illness when a GvHD is present?
It sort of runs the gamut as far as, I see all sorts of types of patients, but the patients that do the best are patients who sort of have just this innate ability to persevere and are just generally happy people. And they have a solid caregiver. They have someone who cares about them, someone that they want to get better for, I think is a really important thing. But again, when they don't have solid caregivers and they don't have a lot of people in their lives, they don't always do the best. They have to have something that they're living for, whether it's to go on a vacation with their spouse or significant other, or if it's to see, a grandchild graduate, or just for their children, themselves to see them graduate and just to be there for them. Even in the sickest patients, they have the most dire situations. I've seen such resiliency and spirit of some patients. And then in other patients that aren't maybe as sick, but they lack the motivation, I think. The motivation, I can't say anything bad about them because I can't imagine how I would feel in that situation about dealing with that myself. But having, some sort of motivation to get better is always important. And I think depression and anxiety and, just the constant sort of ambiguity that their situation has, am I going to get better? Am I not going to get better? I think it's hard not knowing for a lot of patients, and they kind of get stuck. But again, I've seen some patients who just, they know that they're not going to get better, but they still are the happiest and the, most joyous people I've ever met.
Aww.
And it's been they're a privilege to take care of. It's a privilege to take care of them. So.
Wow. Josh, I just love this. I love all your perspective on this.
Well, thank you. Hopefully I've learned something in the last decade, but
I think it's safe to say you have, which leads into my thoughts on quality of life. And I think you've already really covered this, having, something to live for. And, we have patients say, it's so much work to get here. Now I want to enjoy life. And sometimes that life's going to look a little different. I know people don't always love the phrase new normal.
Yeah.
But it really kind of says what we mean, right?
Absolutely. I mean, it does sound kind of cliche to me now, but it's really the truth. Some patients will go back to, 99% of what they were doing pre-transplant or pre-cancer even. But for, I think, a majority of transplant patients who, again, get unrelated donor transplants and have GvHD, the reality is it's not going to be exactly the way it was before.
Mm-hmm.
There's just a new set of circumstances. There's always going to be medications that they need to take and have to stay on top of, and things that they have to be cautious of as far as infections. And they're really going to have to work hard not to become deconditioned from all of the steroids and immune suppression that comes along with the transplant. So
Wow.
Yeah, they have to think about, where they go and should they go out to this function or party, or should they stay at home, or should they wait until, flu season is over, or they really just have to be conscious of all of those things just a little bit more. I think most everybody is now, post-COVID, but transplant patients even more so. And also, I think it sort of gets a little wearing on patients too to have to take so many medications all of the time, because transplant patients who have GvHD have a lot of medications. I have a patient like at least every day who, jokes about, having their second breakfast because of all of the medications they have to take in the morning. So that's a new normal. That's not a thing that they had to do before, but now they have to do it and figure out a way to stay consistent.
Yeah, that's the first I've heard that, but I believe it.
Yeah. If you're a fan of Lord of the Rings, it always kind of gives me a chuckle. But
okay. That's one I haven't seen yet. My son keeps asking me to watch it with him, but I don't know.
Yeah.
So, Josh, as we're starting to wrap things up here, do you have a story of, maybe of a survivor or a recent patient that you really see the results of all the hard work, and it's tough and everything, but they're moving on and getting on with life?
Yeah, I mean, there have been a lot over the years. Sometimes I don't always remember all of the names and things, but I do remember a younger patient I had back when I was new-ish on the night shift on 7 West. I think we were about the same age. So she was in her late 20s.
Okay.
And who had transplant, and she was probably about 2 years out. Chronic GvHD of the skin, of the gut, lungs, who was readmitted with an infection over Christmas time. The holidays is always a huge readmission time for patients. I feel like November, December, always the busiest times on 7 West.
Okay.
Because, patients are getting together with family and trying to, live their lives. And then they end up coming down with something because it's that time of year. It's flu season.
Sure.
She was admitted with, I don't remember, I think maybe RSV or the flu, something like that, and was having a really, really tough time breathing. And I was working the night shift, and so there's not that many people there, but she's just miserable. Getting up and down to the bathroom. She's also, I believe she had some sort of GvHD of the gut as well. And her mom was her caregiver, who was at the bedside 24/7, basically, helping her. And she was just a mess, like just a complete mess. And she knows she was a mess. If she heard me on this podcast, she would probably laugh. But she's someone who I think I'll always remember. She did end up getting better from that particular infection and went home, and she's, as far as I know, doing well still to this day. I've seen her a couple of times throughout the years where she's had to be readmitted with things, but she's just like, every time I think about her, I smile. She still has chronic, GvHD symptoms, but she's just someone who has such a resiliency and such a good attitude toward her situation. Like, she knows that she's not living a life that, someone in their early 30s should be living or, is expected to be living, but she's still having a good time with it. She still has friends. She still goes out. She still, participates in, family functions and goes on vacations as much as she can. And she's someone who's really, I think, reached out and tried to help other people too.
Oh, wow.
I think that's a big thing for patients, is not always being the one being cared for, but having some sort of purpose to themselves and realizing that maybe their situation, they could help someone else get through their infection or their disease, whatever it is. And just use it to be sort of like a peer, to be able to empathize with people in their similar situations. And she's someone who really does that. And yeah, she's just someone I'll never forget.
Oh, I love this.
Whenever I'm feeling down or, I have a really bad day taking care of people, I can always go back to, the good patients that I've had. It's difficult to have those success stories sort of on the inpatient side, because we don't get to see all the patients who are doing well and don't need to be hospitalized.
True.
We see the patients who are the worst of the worst, and they have to be in the hospital to live. But I always go back to those situations, to those patients. It just helps the spirit a little bit sometimes.
Josh, this has been wonderful. One of the other episodes is with a social worker, and everything you just said about having purpose, we really took a deep dive into that. So I think that, you driving that message home again, it's really true. And we have a peer mentor program, a little plug for the NBMT link. So if any listeners out there that want to get involved and be a mentor and give back, we would love to get your name and number. So thank you, Josh, for everything today. This was just tremendous. Thank you.
Absolutely. Thank you.
This has been the Marrow Masters podcast. If you know someone who would benefit from the information in our show, please share this episode with them. And don't miss future episodes of our show. Follow Marrow Masters for free on Apple Podcasts, Spotify, YouTube, or wherever you're listening right now. And to connect with the National Bone Marrow Transplant Link, visit nbmtlink.org or tap the link in our show notes.